Our second presenter will be on medical decision-making for the systemic treatment of FAP-associated desmoid tumors, presented by Dr. Dale Shepard, MD, PhD, FACP, and Director of Phase 1 and Sarcoma Programs at Cleveland Clinic. Dr. Shepard, thank you for joining us.
Well, thank you very much for the introduction to present. Can you see my screen?
Yes, you're good to go.
And you can hear me okay?
Yes.
All right, very good. So as you mentioned, Dale Shepard, I'm a medical oncologist and I oversee our sarcoma program. And I'm at Cleveland Clinic, and with the just mentioned Weiss Center, we have a large population of patients with FAP. And so I frequently see patients coming in with desmoid tumors, and oftentimes they've come in and their local oncologists may not be particularly familiar with them, but they seem to be much more familiar to us because we see a lot of them. And so I guess I'm going to just talk a little bit about really focus on kind of the treatments available, the medical treatments, but really kind of a thought process on how we think about the most appropriate therapies that we're going to give from a medical side. And my colleague is going to talk more on the surgical side here in a bit, but from a medical treatment standpoint, the very first thing, desmoid tumors, much like any type of tumor, and I guess just to reiterate a little bit with what Dr. Hurley had suggested, patients come in confused oftentimes because they have this thing called the desmoid tumor, and maybe that hasn't been described well to them. And tumors in general tend to be scary to patients, but this isn't a cancer per se. It's it's an aggressive benign tumor. And I kind of described it as it's like a cancer because it grows in an uncontrolled way. It's not like a cancer because it doesn't grow into adjacent structures. So if it's up against another organ, it doesn't grow into that organ. And they also don't metastasize. They don't spread to other parts of the body. So, when I first meet patients, I like to oftentimes, if they haven't really had a good overview of what desmoid tumors are, at least give them a little bit of a peace of mind, because that's one of the biggest concerns sometimes, because they have come to a cancer center to see me and they're like, well, no one told me this is a cancer. So reframing is oftentimes important. So first thing when we think about is, what are the goals of our care? What are we trying to accomplish? Are we trying to shrink a tumor? Are we trying to really not necessarily shrink the tumor? Are we just trying to keep it from growing more? Or do we have symptoms? Is the desmoid tumor there but asymptomatic? And do we have a large desmoid that's pushing on something that it shouldn't? Desmoid tumors can cause trouble when they get big and start pressing on vital structures. And so do we need to do something that we can not only shrink the tumor, but doing more quickly? So those are some of the things we have to think about from the very onset is what's our goal? Because that's going to determine what we're going to do from a medical side. And this is something this is a figure from the desmoid tumor working group that really, I think in a lot of ways, at the very top, it sort of defines something very important with desmoid tumors. And again, Dr. Hurley was just talking about resilience, and resilience is important in this particular disease. This is a disease that most often patients are going to have under control for very long periods of time. Once a diagnosis has been made, a very common approach now is really just to get a sense of what that disease is doing from a biology standpoint. Is it growing? Does it need an immediate therapy? So there's more of an emphasis now on what we're calling active surveillance. If we see a patient, they have a desmoid tumor, and again, we're talking about things that are not really large and not really symptomatic and not things that we definitely need to move on. But oftentimes getting a really short interval scan, a month, a 2 months, 3 month scan, get an idea of growth. When you first see that imaging that shows a desmoid, you don't know how long it's been there. And in many cases, biology of desmoid tumors are that they can stay stable for long periods of time untreated. They can get smaller on their own without any treatment whatsoever. And so we'll talk about some trial data in a little bit. It will help highlight that. But active surveillance is a really important consideration when we first diagnose a desmoid tumor. The sort of knee-jerk reaction sometimes to patients is, I have a tumor, I want it out. We'll let our surgical colleague talk about the role of surgery. But more and more, because of concerns for recurrence and really less aggressive surgical management may be the right call. If a tumor is shown to be progressing, a lot of the next steps depends on where that tumor is located. Is it in the abdominal wall? Is it inside the abdomen, in the extremities? Is it in a head and neck region? And we're talking specifically about FAP-associated desmoid tumors here today. FAP-associated desmoid tumors tend to be intra-abdominal or retroperitoneal. Patients I see with sporadic or spontaneous desmoid tumors, much more likely to be in the abdominal wall or in an extremity, an arm, a leg, and under the arm, but far more likely that FAP-associated is going to be inside the abdomen. And those are the ones really we start thinking about medical therapy. So what kind of medical therapies are we considering? We think about traditional approaches, the traditional things that have been looked at in the past would include non-steroidal anti-inflammatories, therapies, targeted therapies, and of those there's two drugs, pazopanib or sorafenib, and then there's chemotherapy, and there's a couple of different chemotherapy regimens that have been used in the past, and we'll talk about each of these. If we talk about non-steroidals, then there's a fair amount of work with non-steroidal anti-inflammatories that took place over the years at Cleveland Clinic. One of the non-steroidal anti-inflammatories that is frequently used in patients that we're going to be using non-steroidal anti-inflammatories is a drug called Sulindac. If you look at actually some of the guidelines, if you look at the National Comprehensive Cancer Network guidelines, which is it's a group of a number of institutions where there are people who get together that treat sarcomas, desmoid tumors, and kind of come up with guidelines in terms of recommendations based on data. They list Sulindac as a drug that could be used in some situations. And part of the reason it's not sometimes given a higher level of recommendation is there haven't been randomized trials. There haven't been trials that really have shown good benefit. There haven't been good trials where you give Sulindac to one group and you take another group and you give another drug or a placebo and see what happens. This is actually data that came from going back and doing a chart review and looking at a number of patients, identifying patients that had desmoid tumors, looking to see what drugs patients had received, and then seeing if there was a benefit. And in this particular case, patients that had gotten Sulindac actually did pretty well. There was one patient that had a complete remission. Complete remission means that on follow-up scans, there's no evidence of disease whatsoever. 7 patients had a partial remission. That means that it was still present on the scan, but there was a significant decrease in size. And 4 patients had disease that was what would be considered stable. 2 patients had progression. So if you look at, again, not in a randomized sort of way, but certainly there were patients that had a response. And when we think about the complications of desmoid tumors, one of those complications oftentimes is pain. And so it sort of serves the purpose of being able to control pain and being able to at least stabilize and perhaps make tumors smaller. So, oftentimes, particularly in patients with FAP-associated desmoid tumors, because of the limitations in the therapies that are currently used, and I intentionally did not say approved, I'll mention that in a second, because of the drugs that are currently used and the time it takes for most of those drugs to actually have a benefit, patients that have FAP-associated desmoid tumors, I oftentimes, when I mention that surveillance and that active surveillance part, I oftentimes will start with Sulindac or active surveillance because oftentimes there's pain. And if I can get a response, I'd like to get that response in a way that in a situation where I'm given a drug that, quite honestly, Motrin or Sulindac, they don't have a lot of side effects. So minimal side effects and the potential to shrink tumor or at least keep it from growing is really not a bad goal. Again, back to Dr. Hurley's discussion of resilience, setting expectations that many of the drugs that we use don't work quickly, may lead to stable disease, And really the discussion about what stable disease means. And if we can keep things at a small, if we can keep a tumor small with a therapy that is well tolerated, that's a reasonable endpoint. If we think about patients that come to me understandably with cancer, want that cancer gone, I get that. But at the same time, we don't have an expectation for most other diseases in medicine that they're cured. Patients take antihypertensive medications for their blood pressure for years, or medications for diabetes for years. And if we can have desmoid tumors that are small, not causing symptoms, with a therapy that has very minimal side effects, that can be a win. If we look at a couple of these drugs in the category of tyrosine kinase inhibitors, there's two drugs that were shown to work in desmoid tumors at the same conference around the same time. One of them is a drug called sorafenib. And sort of back to that point about the fact that about approvals, sorafenib is a drug that is used to treat some cancers. Again, that's back to the point where desmoid tumors are oftentimes treated by oncologists because there's the consideration of using drugs that are used to treat cancers. There are no current FDA-approved drugs for desmoid tumors. And so if you were to say, well, what's FDA approved at this point? The answer is nothing. And so we have drugs that in trials have been shown to be effective, but we don't have anything that's actually approved. If you look at the data here, this is a drug called sorafenib. This is data that was presented about 4 years ago at one of our national meetings. If you look at sorafenib, and this is the graph that we see here, is patients without events, and the events is progression of their disease. So if you have a scan and then you do another scan, did the tumor get bigger? And so we're looking to see, can sorafenib keep tumors from growing, and if so, for how long? And you'll see that red line is sorafenib, and very slow rate of progression of their disease. And placebo was much, much quicker. And now I'm going to point out that this is a placebo-controlled trial. And so placebos are things that we oftentimes think about, that we don't often think about using in cancer trials. But in a setting where we don't have standard therapies that are available, things that are FDA approved, and given the fact that desmoid tumors can shrink on their own, it's appropriate to use a placebo in these situations. So if you're looking at this data and say, well, of course it worked because it was compared to placebo, placebo was a reasonable control. Or if you look at upcoming trials and you say, well, I don't know about a placebo. Well, placebo's a reasonable thing to do in this setting. I mentioned before, these don't work quickly. This is a good example of that. Sorafenib here, it took almost 10 months on average to get a response. When we think about FAP specifically in terms of treatments compared to sporadic or spontaneous desmoid tumors, some of the trials that have been done have not really differentiated. And this is one of those situations. So it wasn't defined in this trial how many patients had FAP. So we don't know necessarily how many patients with FAP would respond. If you look at the response rates, how many patients responded, this is again where we're looking at 33% of the patients had significant shrinkage of tumor. They got sorafenib. But back to that point about spontaneous changes in desmoid tumors, 20% of the patients had a decrease in the size of their tumor on placebo. Pazopanib is the other drug that is commonly used currently for desmoid tumors. In this particular trial, 13% of the patients had a gene mutation, as an APC mutation, which is the common mutation seen in patients with FAP, and 8% in the chemotherapy arm. Looking at sort of similar data, 37% of the patients had a reduction in the size of their tumor. 25%, this was a trial that they compared it to a chemotherapy regimen. 25% that got chemo. So even though it was a pill and not chemo, patients responded, more likely to respond. And again, stable disease, 59% of patients that got pazopanib had stable disease. And so overall, a pretty effective therapy from a response standpoint. And if you look at this graph, this is a type of graph, it's called a waterfall plot. It lists, so each of these bars is an individual patient. And if we were to look at the bars, if you look on that y-axis, if you look at 0, that's no change at all. If you go up to 20%, that's kind of what the upper limit of what we consider stable. So if it grows more than 20%, we call that progression. If you look down on the lower part, 30% is what we consider within 30% stable. So anything above -30 is stable, but you can see there's a significant number of patients that were below that. So those are those patients that had a response. Again, back to the fact that these don't work quickly. You see the progression-free survival is not reached at a year. So how about novel therapies? So interestingly, the pazopanib and the sorafenib were both discussed at the same meeting. Just really quickly, from a reason why we might hesitate to jump into those treatments quickly is they have side effects. This is why I start with sorafenib, because pazopanib can cause things like high blood pressure. They can cause things like nausea, nausea and diarrhea. They can cause fatigue. They can cause one's hair to turn white. They're not exactly benign. It's not exactly a benign drug. Sorafenib can cause fatigue and diarrhea. It can cause hypertension. It can cause alterations in thyroid. It can cause thickening, blistering of the hands and feet. And so for something that patients might be on for a long period of time, that's why I might start with something like Sulindac and try to get control before I go to something like pazopanib or sorafenib, and really because of the side effects more than the benefit. The rate of response is very similar, but the side effect profile is worse. So this is where I will start with something simpler from a side effect standpoint. Two new things that have been discussed actually this month at an oncology conference. The data was presented this month. Nirogacestat and AL102. Looking at those, there's two trials I'll walk you through really quickly here. The nirogacestat trial, it's called the DeFi trial, enrolled patients that had desmoid tumors, the tumor was growing, and either they could not have surgery and had not had therapy at all, or they'd had a prior therapy and the tumor had grown. And patients were randomized, and again, randomized to the drug they were studying, the nirogacestat, or to placebo. And then they looked to see, again, how soon the tumor would start to grow. Thinking back to whether this would answer questions about whether patients with FAP might have a response. In this particular trial, if you look at the number of patients with an APC mutation, 22% in the group that got nirogacestat and 21% in the group that got placebo. And then again, from an intra-abdominal or extra-abdominal location, remember FAP, normally intra-abdominal, 24 and 25%. So certainly there was an enrollment of patients with FAP. If you look at, did it work? The objective response rate, that's that complete response, not anything on the scan, or shrinkage of tumor more than 30%. 41% of patients that got nirogacestat compared to 8% who got placebo, and 7% of the patients had a complete response. If you were to look at patients that had stable disease as well, really significant benefits here, 50%, 34%, 7%. So over 90% of patients either had stable disease or a complete response. A little bit faster too. So I mentioned before about the length of time, 5.6 months until patients had a response. So this seemed to work faster than some of the other therapies that we've discussed before. This is, again, we saw a graph earlier. This graph's looking at progression-free survival. This is just sort of showing it. The blue bar at the top is how quickly patients had progression with the nirogacestat. The black line is patients that were on placebo. And so if you look at this thing called a hazard ratio, that would suggest the hazard or risk of progression. And in this case, the risk of progression was reduced by about 70%. So being on this drug, about a 70% reduction in likelihood the tumor is going to grow. Did patients feel better? Remember I mentioned that Sulindac, really well tolerated. Sorafenib and pazopanib are not insignificant from a side effect standpoint. This tended to be well tolerated. They asked patients about symptoms. They did some testing to look, and they showed significant improvements versus placebo in reducing pain, which again is one of the primary symptoms. Symptom severity was decreased and patients were more functional. Overall, there was improvements in quality of life. So a quicker response, a significant number of patients responding, and patients felt better. There's another trial that was discussed as well. This is a trial with a drug that does not yet have a name. It's still letters and numbers, AL102. Again, it's a very similar drug. I'll step back and mention that this is an entirely new category of drugs. It's something called a gamma secretase inhibitor. So as a category, that's kind of what the group it's in. It's a totally different class than the other two drugs, the sorafenib and pazopanib. This particular drug, AL102, has a very similar mechanism to the nirogacestat. A little bit different the way they were looking at their endpoints. This particular trial is not as far along. They have done an initial phase of the trial where they were trying to figure out what dose that was best to give to patients. And they have said this was actually a reporting of some preliminary data. They are getting ready to expand this trial and do more patients at the dose that was most appropriate. But in this particular trial, the interim analysis, at 16 weeks of therapy, they had 9 patients at that point in time. 1 patient had a partial response. Again, that was more than 30% reduction. 8 of the patients had stable disease. There was less tumor in 7 of those patients. So remember, I had shown you those graphs that showed like the number of patients that have a reduction. All 7 of the 8 patients had less tumor there. And then at 28 weeks, there were only 3 patients at that point. And again, this is an earlier in the phase of this study. They're about to expand into a larger group. But at 28 weeks, so about half a year, 3 patients, there were 2 partial responses and 1 patient had stable disease. All of those patients had less tumor than when they looked at 16 weeks. So essentially, it may well be that they have not had optimal response yet. And so again, this is moving into a randomized phase. So they're going to, much like the study I just talked about, they're going to be doing a phase where they compare it to placebo. So where do we need to go? So what are the future directions specifically for FAP-associated desmoid tumors? Well, one thing, the current guidelines don't really give any guidelines for desmoid tumors that are due to the association with FAP. So I showed you a couple of trials where they've addressed sort of how many patients had FAP for the APC gene mutation, but we don't really have specific guidelines. So in terms of the best therapy to pick, we're not really quite sure where that's going to fall. Are there novel targets? We know that the biology of FAP-associated desmoid tumors is similar to sporadic desmoid tumors, but there is a unique gene mutation. And then just from a biology standpoint, it's clearly a different disease based on the way it presents in terms of location and things. So can we find novel targets? Can we find other drugs that might work better based on a target unique to FAP? Is there a proper sequence for systemic therapies? Do we, right now with most desmoid tumors, I'll either keep an eye on patients or use something that has minimal effects, side effects like Solandac. Then I'll move to the pazopanib or sorafenib. Then I'll move to chemotherapy because I'm increasing similar efficacy, similar benefit to tumor, but increasing levels of complexity from a side effect standpoint. If these gamma secretase inhibitors are approved, that might change the sequence entirely because I might be much more likely to go really early to a gamma secretase inhibitor because I might be able to impact the tumor in a much bigger way early, in a way that's much more easily tolerated, and it might work more quickly. If I have a patient that has a desmoid tumor in their abdomen because of FAP that's pushing on the small bowel and causing trouble, I might be able to get a more rapid response than I will with other therapies. So I think there's going to be a lot of questions about sequencing. And then we need to think about multimodality care, and we're going to be hearing about surgery next. Are there approaches where you do a cryoablation or a surgery to minimize bulk of tumor, have a decreased amount of tumor, but then sort of maintain things at more of a steady state or a stable state? So how do we use all the tools at our disposal to provide the best outcomes with the minimal adverse effects? So with that, I am happy to take questions.
Dr. Shepard, I have a couple of quick questions here.
Okay.
One patient says, I'm confused. In the first presentation of the day, Dr. Pollack described desmoids as locally invasive that have tendrils that can penetrate surrounding tissue. However, you mentioned that desmoids do not invade nearby organs. Wouldn't those tendrils be considered part of the desmoid and therefore considered to be able to invade nearby tissues/organs? Can you just clarify that?
Yep, happy to. So it's a great question. So I guess when I say infiltrate, and I tried to sort of describe it, I'll do that again because it's an important point. And we're gonna hear about surgery, and so we'll get his opinion on this as well. But when I say infiltrate, so if one imagines that another kind of cancer comes up against a bone, it grows into it, it will eat away bone. When you think about metastatic disease, there's actually a hole in a bone. It actually eats into bone. So when I say infiltrate, I mean it actually it would hit a bone and it goes right through it. So the good Dr. Pollack, so Seth is correct. It infiltrates in terms of these little tendrils, but it's really more following along a plane between two tissues. So when it hits bone, it doesn't grow into the bone, it goes along the bone and it grows along the sides, which is why oftentimes when our surgical colleagues take them out, and even though it looks like it's out, they recur because of those tendrils. So it doesn't grow into the bone, it grows along the bone. Does that help?
Yeah, I think that helps. And maybe the next speaker can even go into that more.
I'll talk. I'll be talking about that a little bit. I can comment now. I mean, the only thing I would add is that when it grows alongside those structures, there's often a pretty considerable inflammatory reaction. And so they kind of stick together. And a lot of the problems that can come from desmoids have to do with that relationship between them, where even though it's not grossly invading it, it causes similar complications as if it were invading it, even though technically it probably isn't.
Which again, when we think about our Sulindax and non-steroidals, why those might actually have some benefit.
Okay, yes, I was personally told they had to scrape it off my vertebrae. So that's not totally infiltrating, but somehow attaching as you describe it.
Yeah, I guess I just meant that it doesn't form large erosive changes like you would typically see with some other cancers.
Okay, I have another question that was submitted prior to the webinar. My doctor told me I'm a sporadic desmoid patient, been without any treatment for 15 years, but my doctor told me with aging, I could develop attenuated FAP. Is that true? Can a sporadic desmoid turn into some form of FAP? And what is attenuated FAP?
Yeah, that would be, I guess, I guess I'm not sure what terminology you're really referring to. So, FAP is its own sort of disease and set of complications, if you will. This is not something that someone would likely, after a prolonged period, specifically with a spontaneous desmoid. You realize that most desmoid tumors are in fact sporadic. 80–85% of desmoid tumors are sporadic. So patients with FAP are more likely to get desmoid tumors, but patients with desmoid tumors, that doesn't make them likely to get FAP. If I see a patient with a desmoid tumor, I want to make sure that they don't have FAP, but it wouldn't be something that I would anticipate years and years later we would suddenly discover.
Okay, and finally, last question we have time for. Do you think we know enough about the genetic correlation of desmoids? I have had colon cancer, bladder cancer, and a mesenteric desmoid tumor, but so far genetic testing is negative for FAP.
Yeah, I mean, I think there's, quite honestly, and the medical geneticists could probably answer that better than I could, but I think there's a lot we don't know. I mean, I think that as we learn more, we can start making better associations between diseases and disease states. And there's a lot of work being done in genetic susceptibility and genetic predisposition. when we look at rare tumors like desmoid tumors, they're depending on what source you look at, there are 1,000 or 2,000 diagnosed a year. There aren't large numbers to make good correlations somehow. Oftentimes, quite honestly, our family histories aren't as good as they should be. And so I think these are things that we might find, there may be a gene correlation for that constellation of tumors that we just haven't identified yet.
Okay. All right, thank you. Dr. Shepard, if you'd like to go into the Q&A and answer some of the questions we couldn't present verbally, I'm sure they'd be appreciative. So those questions will still be up. We'll turn the time now over to
Thank you again.
Thank you so much for your presentation.